I will be talking about the established and suspected risk factors for childhood cancers, and particularly for childhood leukemias and also brain cancers. This is based on evaluations of the IARC monographs program, and there is clear evidence that environmental tobacco smoke, in fact that is smoking exposure from the mother or the father, can lead to an increased risk of a rare childhood cancer of the liver, that is hepatoblastoma. There's also some evidence, but not yet sufficient, at the last evaluation for certain types of childhood leukemias, particularly acute lymphoblastic leukemias. There's also other evidence, particularly on ionizing radiation, that is linked to childhood leukemias. And then there is a series of other factors where there is, in the IARC terminology, limited evidence. That means there is a credible association, but in the end, chance bias confounding could not be ruled out with reasonable confidence, such as exposure from painting, which has some biological plausibility due to the solvents, and benzene, for example, is a well-known human carcinogen for adult leukemias. And then there is non-ionizing radiation, the extremely low-frequency electromagnetic fields that have been linked in epidemiological studies to childhood leukemias. However, at the time, the mechanism wasn't understood at all. In fact, there was no idea how this could be caused, and therefore, overall, it was classified as possibly carcinogenic to humans. Well, this talk was specifically about the challenges in ongoing research for childhood cancers. And there we have to consider, first of all, that childhood cancer is a very rare disease as compared, for example, to cancers in adults. And this imposes particular challenges. Typically, with very rare outcomes, you would want to do a case control study, but then with a case control study and traditional assessment of the exposure, you would always have some concern about recall bias. And therefore, if you want to study that in cohort studies with a prospective assessment of the exposure that would not be prone to recall bias, you need large cohorts, or even better, pooling of cohorts. And that is what is going on at the moment. For example, the I4C, the International Childhood Cohort Consortium, to study certain questions, including environmental exposures, in these pooled cohorts. Typically, the time from the first exposure to the cancer outcome, as we know for cancers in the adults, can be very long, in the extreme up to 40 years, for example, for exposure to asbestos and mesothelioma. So in terms of other considerations, we also need to take into account the latency, that is the time from the first exposure to a cancer outcome. And we know from studies of cancer in adults that this can sometimes be very long, up to 40 years. And that, of course, has two consequences for studies of childhood cancer. It's perhaps then not the cancer in children, but it could be the exposure in the children that is relevant for a cancer later in life. And we should perhaps not only consider childhood cancers as such, but also critical exposures during childhood. On the other hand, it is also a possibility due to other exposure effects, meaning that the same exposure in children could have a stronger effect in children as compared to adults, or perhaps shorter latency periods because of increased susceptibility. They are more prone to a cancer due to development of organ systems and other factors. So perhaps with a shorter latency period, there would still be possibilities to find things that you would otherwise not expect in children.